our speaker. So please join me in welcoming Dr. Sun Dai as our Grand Rounds presenter today. Dr. Dai, as many of us know, is one of our wonderful advanced endoscopists and has served as the medical director of endoscopy here at UCSF. He grew up in New Hampshire, watching his father scope, and soon resolved to also go into GI, and earned his medical degree at Baylor, did residency at Cedars-Sinai, and then did GI fellowship at BU and advanced endoscopy fellowship at Penn. He is now an associate professor here at UCSF with research interests in advanced endoscopy outcomes. And today he will be talking about pancreatic cysts. So yeah, take it away. Thanks.
Okay, all right. Thank you guys. Good morning. I have one disclosure. I've done some work with Boston Scientific, nothing related to today's topic. So for pancreatic cysts today, we'll talk about the background and epidemiology. I'll then focus on categories of cysts, which often comes up in a lot of board exams. And then we'll talk about evaluation. And then I don't want to spend too much time on guidelines and challenges, but it is worth sort of skimming over and picking up one or two key points from there. I've been giving this talk since Shreya, Giuseppe, and Vivek were first-year fellows. I was given the option of finding a different topic, and I really wanted to this year, but I realized no one is actually talking about pancreatic cysts, and it is something that I do think should be part of a core curriculum lecture series. When it comes to the pancreas and say when you're studying for your boards, there's not many things to talk about. Acute and chronic pancreatitis, there'll be a few questions there. They're sort of pretty rudimentary questions, sort of internal medicine board questions, if you will. You'll need to memorize a bunch of genetic mutations for hereditary pancreatitis and also mutations that predispose you to pancreatic cancer. And then you'll need to recognize autoimmune pancreatitis. But cysts are really sort of that one section where, at least with board prep questions, they can sort of pick out little details and throw at you, and you'll need to come up with a differential. So that's why I've decided to stick with this topic. But I do sort of look over and try to update my slides every year just to be sure I'm not missing on any new information. Another reason besides my dad that I went to medicine was I was inspired by Dr. Tanner's work. So I often think about sort of like correlate the Tanner stages with like where I was in my training and in my career. So when I was right now we're in February of when I was a first year fellow in February, I was probably around stage 3 to 4. I sort of knew I kind of had an inkling that I would eventually go into interventional endoscopy. But I don't think I truly understood what it meant. I thought it was just, doing a bunch of ERCPs, but this actually does involve, seeing a lot of patients with pancreatic cysts and not just doing the procedure and doing the FNA, but also sort of working them up, surveying them, and making determinations whether someone should be referred out to surgery or just stop surveillance altogether. I do think I graduated in 2014, and in terms of how we treat pancreatic cysts, that's actually changed a lot since I finished my training. We'll start pancreatic cysts. They are very frequently incidentally found asymptomatic. So basically what happened was in probably like the late 90s and the early 2000s when CAT scans and MRIs became more readily available and it was more fashionable to get these studies, doctors started noticing that there's a lot of cysts in the pancreas, and it became no one really knew what to do with them or how they should be managed, whether they should be surveyed, whether they should be resected. Around that time, there were actually a lot of publications, mainly radiology-based studies that came out, just sort of describing how often these cysts show up. So this was and it was generally accepted that they happen in about 2% of the population. And also as we age, we tend to grow more of them, or they're more prevalent in the older populations. Again, this is another, I think this came out in the Red Journal in 2010, showing the rise in incidences of pancreatic cysts by decade. So then the next question became, what is the, how dangerous, how worried should we be about these cysts? And what you would see is that a lot of, there'd be a lot of US FNAs being done on cysts that perhaps didn't really need to get a endoscopic FNA. And people were also having surgeries to remove certain lesions that perhaps didn't need to get removed. So to this day, I still see patients who had Whipples over 10, 20 years ago who now have complications. Usually it's like a pancreatic or jejunal anastomotic stricture, which can be very, very difficult to manage. But these were patients who, when you look back at their original pathology, they were at their community hospital. They had a big cystic lesion and it was removed. And ultimately, if it was not removed, they would still be alive today. So, so a lot of these surgeries were perhaps not necessary. So the Dartmouth group came out in 2013 with a database study looking at 2005 to 2009. And what they're coming up with is basically an estimate. They're saying that in that time period, there were roughly about 1,100 mucin-producing pancreatic adenocarcinomas. At the same time, if we say that 2% of the population has cysts, there should be about just a little shy of 3.5 million patients. So what they determined was that if you have a pancreatic cyst, if you're found to have a pancreatic cyst, at that time, the chances of that being cancer is 0.0332%. And they even went as far as saying if you have something that's 2 centimeters in size or larger, that risk, even though it's a larger lesion, that risk is still the risk of cancer is still quite low. This is actually a more recent study that came out 3 years ago based on insurance claims. What they looked at were patients who got MRIs or CTs and were found to have pancreatic cysts in their diagnosis codes afterwards. They also removed patients who had any pre-existing diagnoses that would have made them at higher risk of getting a pancreatic cyst. For instance, they removed patients who had chronic pancreatitis or pancreatitis, patients with von Hippel-Lindau syndrome, for example. So in their determination, this was based on insurance claims from 2015 to 2017. They actually determined the rate of asymptomatic pancreatic cysts to be even less than 2%. They again show this increased incidence with age. They were also, in some of their patients, they were actually able to get a decent follow-up period. And in that group, they determined that the 5-year cumulative risk of getting cancer was 2%, and the annual rate, this was actually a linear progression. The annual rate of progression was basically less than 0.5%. So what do you guys think about this number? It's pretty low, right? So so a lot of my work, and when I see patients in clinic with a pancreatic cyst, is mainly reassurance that yes, there is a chance of this turning into cancer, but it is extremely low. So this number is low, but it's still higher than, say, the number of GI fellows who've decided to do continuity clinic with a particular senior faculty member. So the chance is not zero. So I still recommend surveillance, but I don't want people to lose sleep about it. Granted, I'm probably more concerned about a 45-year-old who has an 8 mm cyst as opposed to an 85-year-old with a 2 cm cyst. But generally speaking, we do recommend surveillance, and that's what the guidelines will tell you. What they don't do a good job of is saying when you should stop surveillance, however. So we'll move on to categories of cysts. So the differential for when you find a pancreatic cyst can be relatively broad. The red ones here are the ones that would have dysplastic properties, while the blue ones are generally considered benign. When it comes to if you're sort of cramming the night before your board exam and you really didn't go over this topic at all, this would be sort of the simplified version of the lesions that you need to identify or be able to recognize and know what to do with them. So we'll just go through these quickly over some. There's some key terms that often come up on questions that can clue you in. So we'll start with pancreatic pseudocysts. These, of course, are not lesions that people just develop. They usually come after a bout of pancreatitis. Formally, you can't call something a pseudocyst unless it's been there for 4 weeks, or at least it has visual clues that suggest that it's been there for 4 weeks. When you on test questions, if you do an FNA, the fluid is described as often as dark and turbid, or sometimes they call it a like dishwasher fluid. And that's just because this is all just a bunch of debris from pancreatitis that's accumulated and liquefied. If you go by the Atlantic classifications, pancreatic pseudocysts are on the lower left corner. So again, it has to be encapsulated and well defined. We have done cyst gastrostomies on lesions that are younger than 4 weeks, provided that we see a nice, well-defined wall. But on a test question, they're probably going to be very by the book, and you need this to be here for at least 4 weeks. This is different than walled-off necrosis, which is also a collection that has a well-defined wall, but has more sort of semi-solid, semi-fluid components, and often end up being a little more difficult to endoscopically manage because the material itself is very thick. You can't just place a stent and expect all the liquid components to drain out. You will actually have to go in and perform some endoscopic debridement. So serous cyst adenomas. This is actually a fairly common lesion. They're sometimes nicknamed grandmother lesions because the clinical presentation is typically a relatively older female with a large cystic lesion, but in the absence of any symptoms or any biliary obstruction or pancreatic duct obstruction. On imaging, they are the sort of key terms would be a honeycomb appearance. This arrow is pointing at what would be a stellate scar and a calcification. This is allegedly pathognomonic on a CT scan, and though I don't think in my experience, I don't think I've had any radiologists just straight out declare that a lesion is a serous cyst adenoma. There's usually a little bit of a hedge there that, hey, this could be this lesion, but I would still consider getting an EUS or seeing a gastroenterologist for further discussion. Same thing applies allegedly on MRs. You can differentiate these from mucinous cysts, but again, I think it's in this day and age, it's going to be very unusual to have a radiologist just straight out declare that something is a serous cyst adenoma. These things are microcystic, and what I mean by that is when you look on ultrasound, you see these black little pockets. These are the microcysts, and then the rest of the lesion, you actually see these sort of white strands. It almost looks like it's a solid tumor, but it's actually just compiled of many, many little microcysts. Even though this looks like it's solid, these are actually very difficult to get a diagnosis on FNBs because you often just get bland tissue. But usually on test questions, they'll talk about doing a surgical resection, and the key term would be glycogen staining cuboidal cells on a PAS stain. That should clue you in that this is a serous cyst adenoma. And these are actually benign. You should not have to survey these lesions. There are case reports of these things degenerating into cyst adenocarcinomas, but extremely, extremely rare. technically we're supposed to not survey them, but what I often see is that these things can actually grow in size even though they're not undergoing malignant transformation. So someone will get a random scan, a few years later after this diagnosis is made, or maybe their primary physician is just reluctant to abandon surveillance altogether. So that sometimes patients do get sent back to us where there's been interval growth, and we have to consider whether we want to do another biopsy again, or I haven't sent anyone to surgery, but sometimes that does happen. You should get asked on solid pseudopapillary neoplasms, especially because they're fairly rare. The clinical presentation is typically a young woman, and unlike these other lesions, these are actually symptomatic. They can be painful. These are considered low-grade malignancies, even though about 15% of people who have resection still end up having either liver metastasis or peritoneal studding. The reason that these are called pseudopapillary neoplasms is because on pathology, they have these pseudopapillae, or what's often called finger-like projections. So that will clue you in. Again, when you see these, if you come across a diagnosis, the treatment here is surgical resection. Mucinous cystic neoplasms. These are another cystic lesion that has the dysplastic property, and also tends to be found in women. Again, typically in the body and the tail. Unlike the lesions I described before, these are described as oligocystic, and what I mean here is that if you have this big cyst here, you have there's 2 or 3 compartments. There's some septae, but not a lot. I would not say that this is microcystic. And again, if you biopsy here, if you make this diagnosis here, then this is a patient who should be sent to surgery. The pathologic term that often comes up is ovarian-like stroma. Again, this should clue you in that this is an MCN. This is a little more this is a little more of an aggressive lesion compared to a solid pseudopapillary neoplasm, as there's higher rates of malignancy when found in surgical resections. Still, 5-year survival rates are pretty good when you're able to detect this early and resect. The last category of cysts I'll talk about are IPMNs. And these actually come up a little more commonly than MCNs and SPNs. These are often described as grape-like clusters, and this is the one lesion here that's not heavily favored towards females. And they come in different subclassifications. I think the most important ones you need to understand are the top 2 ones. A branched pancreatic duct or a side branch IPMN is exactly as the name implies. You have a grape-like cluster coming off of a side branch. A diffuse main pancreatic duct IPMN or a main pancreatic duct IPMN is simply just it affects the main duct. So your main duct has either a particular segment or your entire main duct is dilated. Even if you have a segmental main pancreatic duct IPMN, the difficult part is that this is a multifocal field issue. So even if you were to say resect this part of the pancreas, what's remaining still has a risk of forming dysplasia. So these patients still require surveillance, even if you were able to resect the dilated portion. Generally speaking, branch duct IPMNs are not as aggressive as main duct IPMNs, and fortunately, the majority of IPMNs are branch duct IPMNs. The thought behind that is the cell lineage of branch duct IPMNs are from gastric type cells, which are typically low grade, and only a small group develop into cancer, while main duct IPMNs come from this intestinal cell lineage. I bring this because this sometimes gets asked on board questions, knowing that the main duct IPMNs have intestinal type lineages. Overall, this is there's been several studies from Japan looking at this, but generally speaking, when you resect a main duct IPMN, there's an up to 40% chance that there's actually cancer there. Now, this number sounds high, but this also, these are main duct IPMNs that have, for one reason or the other, warranted surgical resection, not just sort of you found it and you just said, okay, go to surgery immediately. But branched IPMNs, even though the risk of cancer is lower, it's still there. So it's still a significant number. If you can, if you find this in a 40-year-old, that means that by 55 years of age, that person has a 15% chance of getting cancer. So that's why, particularly IPMNs, you do want to survey these. What were originally the Sendai guidelines, and then they became the Fukuoka guidelines, were written specifically for IPMNs. I won't go through all the details here, and we'll talk about guidelines later. But again, these were not written for just any cyst that you detect. They were written specifically for IPMNs. A few years ago, I include this presentation because a few years ago someone asked, well, how do you tell if you have a main dilated main pancreatic duct? How do you tell if this is chronic pancreatitis versus the main duct IPMN? And typically there's a clinical presentation involved, right? So there's with chronic pancreatitis, there's usually a history of alcohol use. There's probably some chronic abdominal pain or symptoms from chronic pancreatitis. You might see some calcifications here in the pancreatic parenchyma or even within the duct. So this was about 3 years ago. I was asked to do an EUS on a 44-year-old female who, when I first met her, when I was consenting her for the procedure, she told me that she had been drinking heavily, but she just got divorced last year, and this was in January at the time, and she was really looking forward to sort of doing all these things to get her better and just to sort of get back on her feet, we'll say. And I was sort of like, oh boy, this and she had calcifications. This sounds like chronic pancreatitis. So we do this EUS, but of course, and she has a dilated main pancreatic duct. And unfortunately, I don't have the EUS images, but she actually had a 12-millimeter mural nodule that I FNA'd. And it came back as a low-grade IPMN, and her CEA was also quite high. So she actually ended up getting surgery, and there was actually a focus of high-grade dysplasia from her Whipple, and she did great after her Whipple resection. But it was just sort of, it was tricky because this was a case that easily could have been just sort of written off as, oh, this patient has chronic pancreatitis, from alcohol, but she actually had something that was not related to her alcohol use, and she was 44 at the time, so if she had high-grade dysplasia, it is, she certainly most likely would have developed cancer later on in life. So I think, sometimes you can make assumptions, but you can still get fooled. So I'm just glad that we were able to she was actually referred to me. I didn't see her in clinic. She was referred for a procedure, so I'm just glad that she was actually routed appropriately, even if initially it didn't seem like she had a main duct IPMN. So that we'll move on to evaluation. The first category is lab work, and I bring this up because sometimes some physicians do get serum CEAs and CA19-9s. This isn't a requirement. Some people do it, not everyone does. I don't think it's not sort of well established right now, so I don't think you need to worry about that, but just understand that you may see that from time to time. Cross-sectional imaging mainly revolves around getting MRIs, and then obviously endoscopic ultrasound is probably the most important thing when you have a large pancreatic cyst and you're trying to figure out what it is and what you should do with it. In particular, FNA and molecular fluid studies are most important. Cyst wall biopsies and confocal endoscopy, I'll go over quickly, but hasn't really established a foothold in sort of like everyday practice. So again, with the value of getting an MRI or really an MRCP is you can see the size of your pancreatic cyst, but you also want to see if it communicates. For instance, a side branch IPMN, you should see some communication with the main pancreatic duct. You also want to see if it involves the main pancreatic duct, right? And sometimes you can detect solid components. It is limited in terms of what type of cyst it will be. So you're not going to, it'd be very unusual to make a diagnostic call on something just by looking at the MR features. And again, most radiologists, they're very good, but but understandably they're sort of reluctant to make a call on something, especially if it's a patient that they're not examining and they're not speaking to. So the value of an endoscopic ultrasound, it starts first with an endoscopic evaluation. So you want to look at the ampulla for, this is called I think it's called the fish mouth or the fish eyes. I think it's the fish mouth sign. This typically hints that this is a main duct IPMN because you have a lot of mucin secretion coming out, which is why your pancreatic duct orifice is so big. On ultrasound, you want to look for this lesion here. This would be a mural nodule. This sort of implies a solid component. So when you're doing an FNA, oftentimes you want to target this specifically. And again, you can also visualize communication with the main duct. And sometimes you can get some precise sizing of the lesion. Sometimes someone comes in with a CT scan that they saw a cyst, and you do a US. It's not, sometimes I do find them to be a lot smaller than what was caught on CT, which ultimately probably doesn't make that much of a difference, but it does relieve a lot of anxiety when you tell the patient that. So fine needle aspiration. This is the act of inserting a needle into the pancreatic cyst and aspirating the fluid. Unfortunately, now the priority here when you pull fluid out is to send for cytology, but unfortunately the sensitivity is still very low. It still borders around like 50% in the sort of most optimistic of circumstances. And part of that, the reason that is because what you really want are actually the cells on the cyst wall lining. You're not really, so when you're aspirating fluid, you're hoping that you can suck up some of these cells. And I was always taught to really sort of really poke the needle on the cell wall to really phalange the wall, like as if you're going to break off a ton of cells and then get an adequate cytology read, but that just simply doesn't happen. So because of that, you still need cytology, but because of that, you want to send for other molecular markers. Typically, it would be a CEA, but sometimes you include an amylase, and more recently, glucose. And then this is something newer, but molecular testing and next generation sequencing has allowed us to pick up little pieces of DNA and test for certain mutations. I don't think you'll get asked it on a board question, but it is something that I think will eventually become much more popular and much more widely accepted in practice. Another thing is that when you aspirate, you can decompress a cyst, but if you were to rescan the patient several weeks later, that cyst will reappear. So again, and that's because it's the cells that are lining the cyst wall that's secreting that's producing all the fluid properties. So you can't endoscopically make a cyst go away. There's been, at least for about 2 decades now, there will be studies that you'll find where people are using ethanol injections to ablate these lesions. This is very controversial. It's not widely done. If you speak to the surgeons and oncologists that we work with, they're very actively against it. I don't know anyone who actually does these, but it has been described. So the CEA, the CEA again is probably, after cytology, would be the most popular thing that's sent for. This is all based on a study by William Brugge back in 2004, but basically they took 341 patients and looked at their pancreatic cysts and compared to their surgical histological findings. They tested several markers, and ultimately it was just the CEA that was the most that gave them the best degrees of accuracy. So essentially, what they determined was if you have a CA of 192 or above, this is you have sensitivities and specificities that are pretty good for a mucinous cyst. So typically what people talk about is, oh, the CA was greater than 200 or was less than 200, and that it comes from this study. I do want to emphasize that this is not a diagnostic tool. It just sort of clues you in that, hey, if your CEA is over 200, that this cyst is more likely to be a mucinous cyst. And actually, particularly here, if your CEA is less than 5, then it's actually, very, very likely that this is a type of cyst that does not require follow-up. But oftentimes what you'll see is this gets translated into, a high CA means that you have cancer, or that you are going to get cancer, and that's not necessarily true. Recently, about 5 years ago, Stanford came out with this study. So instead of using a CEA, you can actually run the fluid and send it for glucose, which is much more commonly available test, and it's very cheap and can be done very quickly. And so what they're able to find is that if you have a cyst glucose level of less than 50, you actually get some pretty good accuracy rates in terms of determining what is a mucinous cyst versus what's a non-mucinous cyst. So we do this. It does get incorporated into practice. And there's been some other follow-up studies that are making an argument that perhaps the glucose level is not just cheaper, but also more accurate than testing for a CEA. But the CEA is still getting sent for. I think we're still sort of embedded in this practice pattern for the time being. So next generation sequencing. This is done in, you probably have seen this in a lot of things. For instance, when we send brush cytology for biliary strictures, and we're trying to determine whether a patient has cholangiocarcinoma, we also use next generation sequencing. But basically what you're doing is you're taking small fragments of DNA and you're able to produce larger amounts and then use that to detect certain mutations. I'm sure there's people in this crowd who can describe next generation sequencing a little bit better a little more eloquently than I can here. But generally speaking, IPMNs will have a KRAS or a GNAS mutation. So that's usually what you're looking for when you're sending fluid for what you can say is molecular typing or sequencing. Another way to sum it up is on this diagram here. So IPMNs should have KRAS and GNAS mutations. MCNs have KRAS mutations, and these mutations are actually much more rare. I personally haven't had experience where I picked up a mutation from doing next generation sequencing here. This is all based on the molecular pathway. The bottom row here would be IPMN. So if you start off with a normal pancreas cell that is now going to develop metaplasia, there's usually a KRAS mutation that has to occur. And then when you follow on the pathway of IPMNs with low-grade dysplasia to eventually high-grade dysplasia, there's all these other mutations along the way. And that's where a lot of work with next generation sequencing is evolving. They're looking at ways to find mutations along this pathway, and actually along this pathway above. This is for pancreatic intraepithelial neoplasia. So for now, we have the KRAS and GNAS mutations, but perhaps in the future, these mutations will also get analyzed as a way of determining whether someone's cyst has a higher predilection of eventually turning into cancer. Here at UC, we have our pathologists use what's called the UCSF 500. This is just sort of their own proprietary way of doing a next generation sequencing. So we actually use this for when we diagnose pancreatic adenocarcinomas, and we actually send for UC 500s because they want to pick up any sort of Lynch mutation expressions. And we do the same thing for pancreatic cyst fluid. We will send for NGS, and they're, if they're able to, in this case here, they're able to find a BRAF, or sorry, a GNAS mutation. So we know that this lesion was an IPMN. I will say that sometimes this is still limited. Just like how cytology can sometimes come up with inadequate cellular samples, this can also happen with UC 500s. This is often described, this is very, very old school, but there's a string sign. So if you aspirate fluid and then I think you're supposed to dip your fingers in and spread out to like 3 centimeters. And if you say that there's still a gooey string, that this is a mucinous cyst. And this, apparently has very high positive predictive value. I would believe it, but no one I'm aware of is actually doing this. So this is there's a device called a microforceps. So this is based on the concept that you're actually trying to biopsy, you're actually trying to obtain cells that are coming from the cyst wall to figure out exactly what type of cyst you have. So this is often used. I've used it. It doesn't get incorporated into everyday practice because it's sometimes difficult. In order to this forceps has to go through a 19 gauge needle, which can often be a little more stiffer. And oftentimes, if it's a smaller cyst, you just don't have a lot of room to grab pieces. There's 2 disadvantages with the microforceps is that you're grabbing very small pieces. So sometimes they're very hard to see even when you put them in the formalin jar, and then these pieces may not be good enough to get a diagnosis. And then the second thing is there's actually reports of this actually causing pancreatitis in as much to about 15% of patients. I don't think we've had such high rates, but that does happen. The other thing is that it's not like a biopsy forceps where you can just aim wherever you want. You're sort of limited by where your needle will go and where the trajectory of this forceps will take you. But again, this is sort of something that can be used, but isn't always used. Needle-based confocal laser endomicroscopy. This is also something that sounds really awesome in concept, but you're basically using confocal laser technology. And when you look, you're actually looking at cells live. And there's actually some distinguishing features between what is a serous cyst adenoma versus an IPMN. So this gets talked about a lot, but again, it's not very practical. You have to find a cyst that's big enough for you to access the needle and then advance this probe. We used to carry this a few years ago, and we just never used it. And I forgot how much, but it was costing us some exorbitant amount of money per month for it to just sort of sit there. So ultimately, we got rid of it. We haven't gotten requests to do this here, but you can run a spyglass into a dilated main pancreatic duct and take biopsies here to, especially if you are concerned about a main duct IPMN and you're trying to find high-grade dysplasia. What's usually described are these fish egg appearing lesions that you'll find in the main duct. These are what you should be targeting after. There's also a lot of some people are also doing spyglass in known main duct IPMNs who are getting surgery to help sort of map out where the surgical resection should take place. Our surgeons haven't asked us to do this here, but I actually review videos for video GIE for DDW. I noticed there are actually a decent amount of videos from physicians doing this year. The obvious risk of this procedure is that this is pancreatic duct manipulation, so there is a somewhat elevated risk of causing post-procedural pancreatitis from this. And that's why we usually don't jump to doing this unless we're being asked by another, unless we think that it will actually change management of the patient. So I'll go into our last section here, guidelines and challenges. And so the basic challenges are this. There's a lot of pancreatic cysts, and some of them can turn into cancer, but overall, it's still very low. When they do turn to cancer, treatment is very, very difficult. It's pancreatic adenocarcinoma, right? So but at the same time, pancreatic surgery is quite invasive, so you can't really just surgically resect all of these cysts. So what the guidelines are trying to do is they're trying to help you classify what is a high-risk lesion versus what isn't. So again, there's a lot of guidelines. When I was at the end of my training, we'll say Tanner stage 4. The only guidelines that were available at the time were the Sendai guidelines that come out in 2012. And basically, even though these were written specifically for IPMNs, what you would do when you came across a pancreatic cyst is you would just say, well, let's just assume that this is the worst possible thing. Let's just assume this is an IPMN. What would you do here? So what happens is that this leads to a lot of surveillance, it leads to a lot of procedures, sometimes surgical resections on lesions that otherwise that were not IPMNs and that ultimately were benign lesions. So in 2015, the AGA came out with their guidelines, and then we have the ACG guidelines. So again, these were the Fukuoka or the Sendai guidelines, and they really looked at high-risk stigmata, so mural nodules, main pancreatic duct dilated over 10 millimeters. Worrisome features would be of note a cyst that's larger than 3 centimeters. Any sort of transition point along the main pancreatic duct is also what would be described as a worrisome feature. And again, we talked about this is really meant for IPMNs and mucinous cystic neoplasms only. So then the AGA came out with their cyst guidelines. They talk about asymptomatic pancreatic cysts. You'll notice some recurring themes here. High-risk features are a dilated main pancreatic duct, a pancreatic size that's larger than 3 centimeters. The sort of unique thing about the AGA guidelines is they say that if your cyst has been stable after 5 years of surveillance, you can actually stop surveillance completely. And I think this is one area where it's nice when you can bring this up when you have an 80-year-old who's had a cyst that's been stable for 5 years, but it can often be a difficult thing to discuss when you have someone who's middle-aged and you're saying, hey, we can stop this, and when that person potentially has an expected lifespan of up to 20 to 30 years later. The ACG guidelines came out in 2018. These would be the sort of most current GI society-based.
Should I disconnect then?
Yeah.
Okay.
So again, they talk about high-risk features, a pancreatic cyst that's larger than 3 centimeters, a main pancreatic duct that's larger than 5 millimeters. They also talk about they also sort of introduce the discussion of several other issues, but they don't really provide, I wouldn't say they provide guidance, but they talk about you can get a blood test for CA19-9. There is, you may want to consider at a certain age to stop surveillance. They don't say what age. And then there's also the issue of interval growth, because it's been controversial whether interval growth truly represents malignant transformation or not. And they also talk about new onset diabetes. So if you have a patient with pancreatic cyst and new onset diabetes, you may have a lower threshold to consider an endoscopic biopsy. Again, I'm not going to take you through these guidelines. I'm just trying to show you just how sort of complex they can be. But again, the key things here are high-risk features. So a cyst that's 3 centimeters, a duct that's 5 millimeters. They talk about associated solid mass and jaundice, but that's sort of obvious. If you see that, you should pursue an endoscopic workup anyways. You're not really worrying about a benign lesion at that point. And again, once you have your lesion, these are sort of the follow-up intervals that they talk about. Again, very, very complicated. If you have an increase in cyst size, you're supposed to consider a shorter interval or discuss this in a multidisciplinary group. So, not really, I wouldn't say these are very definitive guidelines there, but they're sort of bring this into discussion. I didn't include, there's also European guidelines and also on the far right, the American College of Radiology guidelines. And actually you'll see sometimes on MR reads, you'll see the radiologist will quote that. Again, the general theme that they all follow is a cyst that's larger than 3 centimeters is considered high risk. I guess in Europe, they say if it's 4 centimeters, you should just surgically resect. But also if a main pancreatic duct is at least 5 millimeters, this is high risk, and usually 10 millimeters might even prompt surgical resection. So these are just the general themes. I think there's too many guidelines out there, and I don't think you're going to be asked on any sort of specific minutiae that comes up in, say, something like this diagram here, but just have a general understanding of what the high risk features are. So that's that concludes my talk. So I think the take-home points here would be that you will see a lot of pancreatic cysts because they're common. And yes, a very low percentage of these can eventually turn to cancer. But the overall potential is variable, and a lot of your job is providing reassurance to patients. Just have a general understanding that the key numbers to know are a cyst that's larger than 3 centimeters and a main duct that's dilated beyond 5 millimeters. These are the high-risk features that should prompt you to do more than just routine surveillance. I do think you will need to understand the details of serous cyst adenomas, IPMNs, mucinous neoplasm, pseudopapillary tumors, and also pseudocysts. And just understand that when you do an FNA, what you're really looking for, what you really want are your cytology, CEA, and glucose levels. But in the future, molecular fluid analysis will most likely take on a much more important role as we continue to for FNAs. All right. Any questions?
Thank you so much, Sun. If anyone has any questions, just feel free to either raise your hand